We now go to hallucination. These are perception-like experiences which occur without an external stimuli and which person experiences as part of reality. We can classify hallucinations according to their complexity, sensory modality, mechanism of appearance, and with their psychopathological structure. Hallucinations can be classified as elementary if perceptions are fragmentary and not fully objectified. For example, random noises and flashes of light. Simple hallucinations affect single sensory modality. On this level, we're dealing with full-on objectified perceptions, like voices and objects. Complex hallucinations involve multiple sensory modalities and they are richer in content. They may form meaningful narrations, follow a specific plot, and so on. Now let's look at each sensory modality, starting with vision. I won't be stopping at simple and elementary hallucinations as we've already mentioned what they are. Specific visual hallucinations include otoscopic hallucinations, which means seeing a visual double of oneself. A person may also be seeing a negative double of oneself, or hallucinations can be otovisceroscopic, meaning a person is seeing through their own body and sees their organs. There can also be scene-like visual hallucinations, where a person sees fantastical or unreal scenes play out in front of him, or he himself may even participate in these scenes. A person may also be hallucinating things that are beyond his field of vision. We call this extracampinal hallucinations. In this case, a person may be seeing objects or people behind him or beyond walls. With negative hallucinations, things in the field of view are not perceived. And additionally, hallucinations can differ in size and be huge or tiny, and they can be dynamic or static. With auditory hallucinations, we again may be dealing with elementary noises or fully formed acoustic phenomena like melodies and speech. Voices, as they're often called, can be male or female, familiar or unfamiliar. They may be perceived as coming from outside the environment and be heard in one or both ears, or they can be experienced as coming from inside the head or the body. The voices can be singular or plural. They may be talking to the person or talking beside him and among themselves. The voices may be commenting on what a person is doing, or they may be trying to control his actions. Some voices even demand that they're followed and make threats if they're disobeyed, in which case we call them imperative. In rare cases, we may encounter teleological auditory hallucinations, which are a nicer form of voices, which help the person make plans and work on them. Unfortunately, even they need to be get rid of as soon as possible. Their existence may not be distressing and, for example, may actually help with anxiety, but their presence is still strengthening hallucinatory system and impairs reality testing. They can also change their character and become imperative or of generally negative character. Other common auditory hallucinations are insulting and mocking types, where voices criticize the person. And lastly, we can see antagonistic or contrasting auditory hallucinations, which are voices that are arguing among themselves about the person or about an unrelated topic. Olfactory and gustatory hallucinations are kinda hard to differentiate. They tend to occur together and they're most commonly experienced as unpleasant. Both of them can be experienced as coming from the surrounding environment or from oneself. External gustatory hallucinations mostly manifest as taste of food becoming weird, which often leads to delusions of persecution and of poisoning. Or, if they are self-referential, they may lead to hypochondrial and other delusions. Both versions can also appear secondarily after delusional ideas are already present. External olfactory hallucinations again mostly manifest as food smelling weird or unpleasant odors of gas or chemicals, which are sometimes interpreted as hostile towards the patient, leading to delusions of persecution or accompanying such delusions. As for self-referential olfactory hallucinations, they can lead to or be present alongside delusions of hypochondria, body dysmorphic disorders, and so on. Tactile hallucinations can range from vague sensations to fully formed tactile experiences. We can see more specific types like formication, where we see tactile hallucinations that are experienced as bugs crawling under or on the skin. We most commonly see this with alcohol withdrawal in delirium tremens. We can also see different qualitative types of tactile hallucinations, ranging from thermal to haptic and to erotic. Compared to synestopathies, tactile hallucinations are experienced as perceptions coming from the external world. They have clearer localization and are of simpler sensory quality. Visceral hallucinations are experienced as coming from inside the body. They most commonly have to do with organs or external objects that a person is convinced are placed inside of him. For example, a person may be complaining that his organs are shifting places or that there's a radio transmitter placed in his stomach. Visceral hallucinations often tend to bleed into synestopathic experiences, especially with paranoid schizophrenia and severe affective disorders. With schizophrenia, visceral hallucinations tend to have fantastic interpretations. For example, a person may be convinced that their liver is moving around in their body and is controlling their thoughts. Let's now look at mechanisms of their appearance and more specific types of hallucinations. We most commonly see hallucinations that arise spontaneously without an external stimuli. I've classified them here as ordinary. With functional hallucinations, one sensory analyzer perceives both the real stimuli and also the hallucination. If the real stimulus disappears, so does the other one. For example, hearing voices when water is running. Two analyzers are involved with reflectory hallucinations. One perceives the real stimuli while the other one perceives falsely. For example, seeing a shadowy figure in the room when phone rings. Psychogenic hallucinations arise from strong stress, trauma, or under the effect of fear. They are often transient. Some of you may have experienced sleep paralysis or other hypnagogic or hypnopompic hallucinations. They are considered normal when falling asleep or when waking up. Other types include induced or inspired hallucinations, which we usually see, for example, with hypnosis. They require emotional involvement and are most commonly visual. Obsessive types of hallucinations are experienced as intrusive, and despite insight, the patient cannot get rid of them with an act of will. Now come more traditional types, starting with hallucinations of Charles Bonnet, where we mostly see visual and auditory hallucinations with sensory deprivation or impaired activity of a sense organ. Insight is usually preserved, and hallucinations often fade or become less frequent as the brain adjusts to the loss of a sense. With Dupre's hallucinations, we're dealing with hypertrophied imagination, where internal representations become too real, and it's usually seen with children, elderly, or with disorders like conversion disorder. Segler's associative hallucinations have to do with real perceptions acting as associative cues that determine the thematic and semantic content of the hallucination. For example, a nurse says, "Take your pills," and the patient hears, "They're trying to poison you with those pills." So with this type, context fills in the content of hallucination. Here are some more classical types of hallucinations which have somatic causes. I won't be going in detail here, but you can look them up if you're interested in the topic. The three main structural types of hallucinations we see are hallucinoid, true hallucinations, and pseudo-hallucinations. Hallucinoid refers to incomplete, unstable hallucinatory experience, usually seen with clouded consciousness. They may precede or accompany the development of delirium or be prodromal for early schizophrenia, affective disorders, and so on. They may also present with extreme physical or mental fatigue. Common examples are minor auditory or visual phenomena like fleeting voices or shadows. The distinction between true hallucinations and pseudo-hallucinations is very important. The key difference is subjective localization and objectivation of the experience. With true hallucinations, the patient experiences them as fully external and vivid. Just like any real stimuli, the patient does not doubt their reality. So the voice is heard from behind the door, or a figure is seen actually present in the environment. In contrast, pseudo-hallucinations are not fully objectified in external environment and have a distinct sense of madeness to them. The patient typically recognizes that the experience is somehow produced in the mind and is only for him, even if it feels intrusive and alien. For example, the patient may say, I hear voices inside my head, or I see images that are not like ordinary imagination. As for insight, it's usually absent or partial in both cases. Lastly, I want to look at hallucinosis. It involves fully formed hallucinations, which are usually visual or auditory and often are repetitive or stereotypical. They are invasive, persistent, and appear in a clear state of consciousness. The person realizes that they're hallucinating and does not act upon them. This condition can have an underlying somatic or psychogenic cause, and it can be acute or chronic without development of other psychotic symptoms. That about covers the entirety of perception and its clinically significant pathologies. Thank you for listening, and see you next time.